Respected Chairperson, dear colleagues, management of coexisting cataract and glaucoma is a real clinical challenge. At present, we have two approaches to deal such cases. The first approach is two-stage surgeries, where glaucoma operation is performed at the first stage, followed by cataract extraction at a later date. And the second approach is one-stage combined surgery, where cataract surgery and glaucoma surgery are performed simultaneously. Glaucoma operation can be performed either of penetrating type or of non-penetrating type. Both the surgeries, cataract and glaucoma, can be performed at the same site or at the different site. Presently, the penetrating glaucoma surgery is the most common surgery which is being performed all over the world. Objective of our investigation was to investigate the surgical outcome of one-stage, two-site combined surgery for coexisting glaucoma and cataract and compare the results of this procedure with the results of cataract surgery in trabeculectomized eyes. We have 60 cases, 60 eyes under our observation in two groups. In combined surgery group, included 26 patients, and the two-stage surgery group, 34 cases. All the patients in both the groups were age and sex matched. Visual acuity varied from projection of light to 0.1, and in both the group, most of the patients were suffering from glaucoma of second stage. Lens swelling, lens subluxation, pseudoexfoliation were among the complicating factors in both the groups. All the patients in both the groups had complete ophthalmic examination preoperatively. We have included in this study only those patients who have undergone two-site surgeries for subcompensated open-angle glaucoma and cataract with a minimum follow-up of 6 months. All the cases were operated by one surgeon. Outcome measures were visual acuity, intraocular pressure, and complications arising intraoperatively in early and late postoperative period. A p-value of less than 0.05 was considered statistically significant. Trabeculectomy in both the cases was performed superiorly with a fornix-based conjunctival flap. Cataract was extracted by clear corneal incision, phacoemulsification, and wherever indicated, we used trypan blue and iris hooks. All the cases were operated by using phacoemulsifier system Galaxy 1 with peristaltic pump manufactured by Appasamy Associates of India. Our preferred technique was stop and chop and quick chop, and ultrasound energy was used either in pulse mode 8 pulses per second or micropulse mode 25 pulses per second. Small video clip for kind attention. Preparation of conjunctival flap and partial thickness scleral flap. Then after this, cataract extraction was done by using clear corneal phacoemulsification, implantation of a foldable intraocular lens by using disposable injector, we use 1 millimeter diamond knife to make a parasynthesis at the base of the scleral flap. Trabeculectomy was done by using Cayley's Descemet punch. We do peripheral iridectomy, and after that, scleral flaps and conjunctival flaps were sutured in their respective places. Results. We do find statistically significant difference in the best corrected visual acuity in the immediate postoperative period. But after 1 month of postoperative follow-up, the difference was non-significant in both the groups. Intraocular pressure at the last follow-up was under control in both groups. We did not need any additional medication. During operation, we observed that the surgical complication rate was significantly higher in the two surgery group, which approached nearly 50%. We required additional surgical manipulations in the patients of this group For example, saniculitis, which was required in 11 cases and resulted in punctate hemorrhages from pupil margin requiring prolonged irrigation in 8 cases. We had 2 cases of PC rupture in this group also, with vitreous loss in 1 case. In this case, we implanted iris claw intraocular lens behind the iris. Ultrasound energy used in both the groups was same. There was no difference. In spite of higher surgical complication rate in the 2 surgery group, we did not find any statistically significant difference in the postoperative complication in the early postoperative period. However, we noticed that the choroidal detachment, bleb leak, higher intraocular pressure, swelling of the lens requiring immediate extraction of cataract with intraocular lens implantation was more common in the 2 surgery groups. In the late post-operative period, we observed that in both groups we have deformed pupils. These were those cases where we used iris hooks. We had cases of anterior capsule fibrosis, iridocyclitis, PCO requiring NDR laser, capsulotomy. They were the cases in the 2-stage surgery groups. We had 1 case of bullous keratopathy, which occurred after 1 year of follow-up in the 2 surgery group. The difference, again, in both the groups was non-significant. Hence, our study showed that there is no significant difference in the results of both the approaches. Combined surgery offered certain advantages like cost reduction of surgery, less duration of hospital stay, early rehabilitation, and the most important, the psychological advantage of 1-stage surgery. This allowed us to conclude that 1-stage combined surgery is a safer and effective procedure for managing coexistent glaucoma and cataract. Thank you very much.
I invite the next speaker, Dr. Phil from Italy, to speak on the topic on 12-month analysis of iStent trabecular microbypass shunt in combination with cataract surgery.
Mr. Chairman, dear colleagues, it's well known that the standard of surgery for glaucoma is trabeculectomy, but we have many complications, and so many other less invasive surgeries have been devised, but some of them are manually difficult. And most of the surgeries we do actually don't go to target the physiological deflux, which we know is located at the juxtacanalicula trabecular meshwork at the Dischlem's endothelium. So what we are presenting here is a stent which is supposed, well, a very small one, as you can see when compared to 1 cent of euro coin, which is supposed to be inserted into the Schlem's canal and to drain the aqueous from the anterior chamber directly into the vesiculaire veins. We are presenting the results of a multi-center, non-randomized, open-label, multi-country study about this stent, evaluating the safety and the efficacy mainly in primary open-angle glaucoma, where uncontrolled by the current ocular medication and after successfully phaco emulsification. All the patients discontinued the therapy after the surgery, and they were resumed only if the doctor deemed this was necessary. And we are presenting the result, the interim result at 12 months. So the patients were admitted if they had more than 18 millimeters of IOP and they were using more than 1 medication, and they were out if they had any other kind of glaucoma, and especially if it was impossible to see the trabecular meshwork, or it was thought it was difficult because of refractive surgery, for instance, to measure IOP accurately afterwards. A few hints about the surgery. I hope this works. Okay, first of all, you have to widen the angle so that you can see it. Then it's you have to see the angle, so the head of the surgeon, the head of the patient and the surgeon have to be almost 45 degrees, so that you can use gonio lens to see the angle. And here you can see that sometimes after the surgery you can see the Schlem's canal very well. Then you insert this introducer into the anterior chamber. You go right where the angle is, you angle it almost 45 degrees, and you insert the stent into the Schlemm's canal. And you have not to see any movement or any problem with as we to go smoothly into the Schlemm's canal. The stent is released. Sometimes the stent is not in the right position at the first time, so you have to reposition it. But what you actually don't have to do is to push very strongly, as this colleague of mine is doing, so that it means you are in the wrong position. You always have a blood reflux that you can aspirate through the IA, and afterwards you can see the stent nicely placed in the Schlemm's canal. Okay, the patients were evaluated in the first postoperative days and throughout 12 months for IOP, number and type of medication, and adverse events. Of course, we had a look at the anterior segment and through gonioscopy at the stent. Out of 58 patients, 48 did the all surgery, and we have the results at 12 months in 42 patients. The characteristics are here. Most of them were primary open-angle glaucoma. The safety data are on all the patients, so mainly we had problems intraoperatively. Most of them were stent malpositioning, and actually postoperatively some of the stent had to be repositioned. In 3 patients, the drop in intraocular pressure was not enough, so they had trabeculectomy. And in 7 cases, after 6 months approximately, we thought that the stent was occluded, but nevertheless, 5 of these patients had an IOP reduction or a reduction in medications. We didn't have any big problems, as we can see with trabeculectomy, such as hypotony or flat anterior chamber choroidal effusion and things like that. These are the results as far as the pressure is concerned, and we had a qualified success in almost 62% of patients and a complete success in 50% of patients. The reduction compared to the medicated pressure before the intervention was statistically significant, and it ranged from 14 to 26%. Most of the patients had a reduction in the number of medication, which was statistically significant, going from 1.6 on average to 0.4. Well, what we can say after this experience is that we had a quite good reduction, although it's not a big reduction as we were used with trabeculectomy or has been shown before by Dr. Tetz. But this reduction is on average higher than what we see with just cataract extraction alone. Most of all, the implantation is safe and we didn't see any major complication. The conjunctivis is untouched, so you can do trabeculectomy afterwards. The major problem is the positioning, the exact positioning, and the eventual occlusion of the stent. And here you can see, you can look at it gonioscopically, and as I said before, seeing blood near at the same level of the stent is indicating that this is in the right position. Of course, you can use UBM to have a further look to this. Our experience, our results are certainly preliminary, but in some way promising. So we think that longer follow-up and additional clinical studies are warranted. And I thank you all for your attention.
Thank you very much. I find this also very interesting because we have been trying to use such stents or tubing from the outside when doing